Hello and welcome to the topic Hypertension in the Cardiology module. By the end of this topic, you should be able to define hypertension, classify hypertension, list the causes of hypertension, outline the pathophysiology of hypertension, describe the clinical features and investigations, discuss the treatment modalities of hypertension, and explain the complications of hypertension if left untreated. Let's get started. Firstly, NICE recommends measuring blood pressure in both arms when considering a diagnosis of hypertension. If the difference in reading between arms is more than 20 mm mercury, then the measurement should be repeated. If the difference remains more than 20 mm mercury, then subsequent blood pressures should be recorded from the arm with the higher reading. It should of course be remembered that there are pathological causes of unequal blood pressure readings from the arms, such as supravalvular aortic stenosis. It is therefore prudent to listen to the heart sounds if a difference exists and further investigations if a very large difference is noted. NICE also recommends taking a second reading during the consultation if the first reading is more than 140 over 90 mm mercury. The lower reading of the two should determine further management. NICE suggests offering ambulatory blood pressure monitoring or home blood pressure monitoring to any patient with a blood pressure of 140 over 90 mm mercury and more. If the blood pressure is more than 180 over 120 mm mercury, admit the patient for specialist assessment if there are signs of retinal hemorrhage or papilloedema, which is a sign of accelerated hypertension, or life-threatening symptoms such as new onset confusion, chest pain, signs of heart failure, or acute kidney injury. NICE also recommends referral if a pheochromocytoma is suspected, where the patient might have labile or postural hypotension, headache, palpitations, pallor, and diaphoresis. If none of the above is present, then arrange urgent investigations for end organ damage. If target organ damage is identified, consider starting antihypertensive drug treatment immediately without waiting for the results of the ambulatory blood pressure monitoring or home blood pressure monitoring. If no target organ damage is identified, repeat clinic blood pressure measurement within 7 days. So what is ambulatory blood pressure monitoring? At least 2 measurements per hour during the person's usual waking hours. For example, between 8 a.m. and 10 p.m., use the average value of at least 14 measurements. If ambulatory blood pressure monitoring is not tolerated or declined, home blood pressure monitoring should be offered. Home blood pressure monitoring, for each BP recording, 2 consecutive measurements need to be taken at least 1 minute apart and with the person seated. BP should be recorded twice daily, ideally in the morning and the evening. BP should be recorded for at least 4 days, ideally for 7 days. Discard the measurements taken on the first day and use the average value of all the remaining measurements. NICE made a further recommendation in 2019 suggesting that we should consider antihypertensive drug treatment in addition to lifestyle advice for adults aged under 60 with stage 1 hypertension and an estimated 10-year risk below 10%. With regard to the causes of this disease, arterial hypertension can be divided into primary, secondary, and gestational hypertension, which will be discussed shortly. The majority of individuals with hypertension suffer from primary hypertension, which is defined by the fact that it is idiopathic in nature without any secondary causes. This means that diagnosis is made by the principle of exclusion. There are some risk factors associated with this form of hypertension that usually occur in individuals over the age of 30. These include, in particular, nutritional factors such as excess weight, alcohol consumption, and a diet high in sodium, stress factors, smoking, and advanced age. Secondary hypertension is a type of hypertension with an underlying and potentially reversible cause. It makes up only a small fraction of hypertensive cases. Secondary hypertension should be considered in the presence of suggestive symptoms and signs such as severe or resistant hypertension, age of onset younger than 30 years, malignant or accelerated hypertension, and an acute rise in blood pressure from previously stable readings. Causes of secondary hypertension include renovascular hypertension, hyperaldosteronism, coarctation of the aorta, obstructive sleep apnea, in endocrine diseases such as pheochromocytoma, thyroid disease, Cushing's syndrome, and finally drug-induced hypertension. Another type of arterial hypertension is the hypertensive disease of pregnancy. Hypertensive disorders of pregnancy include a variety of diseases which can occur in pregnancy, such as gestational hypertension, where the hypertension is not associated with proteinuria, preeclampsia, where the hypertension is associated with proteinuria, and eclampsia, where preeclampsia is present with at least one convulsion episode. Now let's look at how hypertension develops. Arterial hypertension develops due to a disturbance of the regulatory mechanism that usually keeps blood pressure constant. This includes increased peripheral resistance, an increase in cardiac output, or a combination of both. During the progression of the disease, several compensatory mechanisms take place, consistently keeping the blood pressure at an elevated level. In order to maintain cardiac output, cardiac hypertrophy occurs, which helps to permanently withstand the increased pressure. The resistant vessels hypertrophy as well. The baroreceptor reflex that usually registers increased blood pressure values is shifted, allowing higher blood pressure values to be considered normal. The kidneys play a role in this compensatory process as well. Even though renal blood flow and glomerular filtration rate are kept constant for most part, an increase in sodium excretion accompanies the increase in blood pressure in order to counteract hypertension. The influences of the release of renin as well as the changes in renal sodium absorption, for instance, on pressure natriuresis, are the topic of this discussion. Symptoms of arterial hypertension frequently manifest themselves rather late. Typical symptoms include early morning headache, sleep disorders, dizziness, nosebleeds, and palpitations. In cases of secondary hypertension, symptoms of the individual underlying disease will accompany those of hypertension. Diagnosis of hypertension begins with medical history. Gathering a patient's medical history is essential. It helps in figuring out possible symptoms and reveal previously measured blood pressure values as well as possible risk factors. It is also necessary to inquire about any medications the patient is or has been taking, such as drugs that inhibit ovulation and corticosteroids. Previous illnesses must also be inquired about as well as the patient's family history. The focal point of diagnosing arterial hypertension is the non-invasive measurement of blood pressure. Here, it is necessary to make sure that elevated blood pressure must be established by taking at least 3 readings on 2 different days. It is also a fact that the first readings are frequently 10% higher than the subsequent readings. With regard to lab diagnostics, hemoglobin and hematocrit are blood parameters that may indicate anemia due to underlying renal disease. Renal function may be tested by measuring creatinine and eGFR levels. Potassium levels will provide more information if Cohen syndrome is suspected. Furthermore, other parameters such as cholesterol, triglycerides, and glucose should be measured in order to determine the risk for atherosclerosis. In order to evaluate the presence of endocrine hypertension, parameters such as free T3, T4, and TSH, aldosterone, and renin may be measured. Urine analysis may be another test option because microalbuminuria may be an early indicator of renal damage, especially in diabetic patients. Determining glucose levels is necessary to rule out potential diabetes mellitus. Nitrite levels may reveal urinary tract infections, and catecholamine in combination with severely high diastolic blood pressure are indicators of pheochromocytoma. Instrument-based diagnostics is primarily used for diagnosing secondary hypertension, and this includes ECG screening to rule out left ventricular damage or coronary artery disease. Chest X-rays may be reasonable as well in order to determine the presence of any heart chamber dilatation. Echocardiography is used to determine the ventricular circumference and to rule out any impairment of the pump function of the heart. Carotid Doppler sonography, renal sonographies, or color duplex sonographies of the renal arteries may also be an option in specific situations. When it comes to therapy of hypertension, let's begin with non-pharmacological measures. Unless in cases of hypertensive crisis or hypertensive emergency, we can always initiate the treatment with non-pharmacological measures, and these therapy include weight reduction until a BMI of approximately 25 kilograms per meter squared had been achieved. Diet low in sodium with no more than 5 to 6 grams sodium chloride per day, ideally 3 grams a day. Adjusting one's lifestyle to reduce hypertension, such as smoking cessation, alcohol reduction, coffee intake reduction. Medications that may cause hypertension may no longer be taken either. In addition, dynamic conditioning training to include sports such as swimming, jogging, or cycling should be pursued 3 to 4 times a week. This is a flowchart showing the management of hypertension as per latest NICE guidelines. Pharmacological therapy may begin as monotherapy first. However, blood pressure values strongly deviate from normal blood pressure values, or in cases of comorbidities, primary combination therapy should be initiated. The first-line agent in the treatment of hypertension is ACE inhibitors of one is less than 55 years old. For those 55 years and above, calcium channel blockers are first-line monotherapy. They can be used in combination if monotherapy is not successful. Step 3 will be adding a diuretic to the previous combination. And lastly, if hypertension is still refractory, may consider to add on alpha or beta blocker. For patients less than 40 years, consider specialist referral to exclude secondary causes. This table outlines the classes of antihypertensives and their respective descriptions in initiating therapy. Now, finally, the complications of hypertension. The problem with arterial hypertension is that in many cases, it is not diagnosed for a long time and it's not treated at all or only to an insufficient degree. In addition, lack of patient compliance caused by the patient not feeling ill may hinder therapy as well. This leads to secondary diseases, frequently affecting the heart, kidneys, the brain, and the eyes, or that manifest themselves in the vessels of lower extremities. These diseases are frequently the result of atherosclerosis in the affected sections of the vessels. Important secondary cardiac diseases in the context of hypertensive heart disease are left ventricular hypertrophy, left ventricular insufficiency, as well as coronary artery disease. Cardiac hypertrophy occurs in order to withstand the increased pressure. The critical heart weight is at 500 grams, and if this weight is exceeded, the heart muscles can no longer be supplied sufficiently, finally resulting in left ventricular insufficiency. As a result of atherosclerotic changes in the coronary blood vessels, the coronary reserve is impaired to the point that in individuals with hypertension, the increase in cardiac output on effort may not be sufficiently ensured. Therefore, this may more frequently result in angina pectoris, myocardial infarction, or sudden cardiac arrest. Hypertensive nephropathy is accompanied by damage to the kidneys, which may lead to microalbuminuria associated with endothelial damage, similar to what happens with diabetic patients. Years of arterial hypertension may lead to pronounced nephrosclerosis with terminal kidney failure. Arterial hypertension may result in transient ischemic attacks, as well as cerebral infarction, hypertensive hemorrhaging, or acute hypertensive encephalopathy. The risk of suffering a stroke can significantly be lowered with antihypertensive therapy. Hypertensive retinopathy is usually the result of broadening atherosclerosis in the vessels of the retina. Vascular diseases caused by hypertension include peripheral arterial disease, abdominal aortic aneurysm, as well as aortic dissection. So let's summarize. Hypertension is a non-communicable disease which is prevalent in the developing and developed countries. This condition can be broadly categorized into primary, secondary, and gestational hypertension. Primary or essential hypertension is a diagnosis of exclusion. Secondary hypertension causes such as coarctation of the aorta, renovascular causes, endocrine disorders, and obstructive sleep apnea should be excluded before a diagnosis of essential hypertension is made. There are 4 main groups of antihypertensives used in the treatment of hypertension, and these include ACE inhibitors or angiotensin receptor blockers, beta blockers, calcium channel blockers, and diuretics. A good control of hypertension is imperative to prevent complications like cerebrovascular diseases, coronary artery disease, peripheral arterial disease, and retinopathy. We have come to the end of this topic. Thank you.